Hi there, and welcome to the 2019, oh my gosh, I am getting old, ICD-10 CM code changes. That's me right there, Ed O'Byrne. I am a coder and former physician assistant and a clinical documentation improvement professional, and currently the director of HIM Revenue Integrity for Healthcare Resource Group right there. Get to have a lot of fun consulting and education, and once in a while, if I'm lucky, I can actually do a little bit of production coding and auditing when I get a chance. So as we go through the new ICD-10 CM codes for 2019 and changes, take about 35 minutes. There's a few things I'm going to ignore. If you look at the raw number of code changes, you'll see the number is quite large. However, many of those were spelling corrections, and unless they were otherwise interesting or humorous, I will not pay any attention to those. Deletions of extraneous spaces, I won't show you any of those. There was a surprising number of those where there was just an extra space, and I guess the nitpickers at CMS decided to take those out. There are some code changes which are in the descriptor where there's maybe just a tiny little change in the way it's described that are trivial and what I would think of as completely obvious. Not the kind of thing that you're going to learn anything from reviewing, not anything you're going to get wrong by indexing or looking these up in the tabular. And then certain corrections of concepts, if they are equally obvious, I won't mention those unless, again, they're interesting or educational from a coding, anatomy, physiology, pathophysiology standpoint, because if you know me, I love those kinds of things. For each of the slides, for the most part, I'll stick to a similar kind of format as you see here. We'll have the chapter, and I'll go through the body systems with two rare exceptions in order of your CM book. So if you've got your book handy, I recommend you take it out. Pause this periodically when you hit something interesting in the presentation. Find that family of codes in your book so you can kind of see where the new code changes are coming if you're using your 18 edition, or where the new codes or changes are, and if you have your 2019 manual. What I'll do is first describe the general description of the change so you can kind of conceptually understand what's happening in the code changes. We'll refer to which elements were changed, like specificity, which is most of them, laterality, location, for example. I will try to give an example existing code that we've got to sort of orient yourself to where in ICD-10 you are dealing with the changes, and give an example of one of the new or changed CM codes. There are several instances where, as I mentioned, greater specificity, and I'll use the term split, which is to say oftentimes an existing other code adds a decimal or adds another character and adds a couple more varieties of them. So that's one split into two or more other varieties. And that actually accounts for the predominant number that you'll find in this presentation. I should warn you, I'm experimenting with some new transitions in my presentation here. Some are cool, some are corny, but just bear with me, and maybe that'll keep you on your toes, and let me know what you think. Okay, we'll start with the endocrine, nutritional, and metabolic system. There is one instance of neoplasm that has to do with eyelids, and there's a lot of eyelid changes, which I'll save for the eye chapter. But in this section, we have some endocrine changes. So one is kind of trivial, and this is a sort of an oversight. Primary hyperoxaluria, to elevated oxalic acid in the bloodstream, can predispose to kidney stones and other conditions too, and add the primary. And that is about as arcane as I'm going to go in this presentation, unless it's funny again. Amino acid metabolism disorders split into, and this is a good example of where the code, the other was split into an other, add a 9, and then now we use a 8-1 and E7526. So we added gamma aminobutyric acid metabolism disorder and a sulfatase deficiency. Those are some nutritional and endocrine changes. Also hyperlipidemia. So there are several other very specific hyperlipidemias that you'll find, but the other hyperlipidemia, E78.4, add a 9 to that, and that becomes our new other hyperlipidemia, and we will all use that plenty of times. But elevated lipoprotein A in particular has its own code now, and plasminogen deficiency specificity. All right, on to mental, behavioral, and neuro disorders. So cannabis is now regarded to have, for ICD-10 purposes, withdrawal. There was already a dependence, But by some definitions, a dependence is heralded by or defined by the possibility or the reality of withdrawal. So we add to cannabis dependence and cannabis use withdrawal. So simply added a withdrawal for both of those and a new distinct code F12.23 and 93. Postpartum psychosis. Now that was previously indexed postpartum depression to this, which is actually pretty inaccurate and kind of stigmatizing. Thankfully, this has been split out into F53.0 postpartum depression, which is unfortunately, it's a common code and it requires some clinical attention and accurate coding. And then we have sort of twisted the generic postpartum psychosis, oh, mind your T there, puerperal psychosis. So it could be postpartum or around childbirth area, puerperal psychosis, F53.1. Now this one is kind of cool. It's kind of unfortunate too, but Munchausen's disease, okay, aka factitious disorder. A factitious disorder is where a patient fakes either on themselves or another person a disease in order to get attention, medical attention or care. They may or may not think they have the disease, but the intention is to essentially consume medical resources and the attention that comes with it. This is distinct from malingering, in which a patient may fake an injury or a condition with or without exam findings, like putting blood in their urine, or I swear I took care of a patient once that put magic marker on her ankle to fake an ankle injury. There, the incentive is either money or some sort of compensation or getting out of work or getting out of school was in this case the case. That's malingering. Factitious disorder is convincing the medical community that the disease exists so that they treat it. So what's been done to this factitious disorder family is to add imposed on self and imposed on other. So imposed on self is straight Munchausen's disease. So that's a patient that fakes a disease so that they can see the doctor a lot or be in the hospital a lot and get that attention. There are some other terms for that. The hospital hopper, it indexes to Munchausen's disease as well. A peregrinating patient as well, but again, not malingering. And then further divided between factitious disorder with primarily psychological symptoms, primarily physical symptoms, or both, or unspecified. Here's the example code F68.12 with physical signs and symptoms. Now we add a new code, which is the factitious disorder imposed on another. This is Munchausen's by proxy. This is the kind you see in the documentaries where a caretaker or a nurse will make another person ill, like and poison them or inject potassium into their IV so that the patient gets sick, and then the caretaker or nurse or whoever gets to swoop in and be the hero. And that's the kind of attention they're seeking, is not for them being sick, but by taking care of the sick person too. It's pretty vicious stuff. But that's Munchausen's by proxy versus Munchausen's disease. On to the nervous system. A couple little housekeeping changes here. Clonic hemifacial spasm. Laterality is added. We got a code for right, left, bilateral, and unspecified. And there they all are. Muscular dystrophy, perhaps not super common, but a more utilitarian code choice. Because the traditional is sort of Jerry's kids muscular dystrophy, the Duchenne muscular dystrophy, which affects all muscle groups but the lower extremities more so, aka Becker muscular dystrophy, now has its own code, not just the generic muscular dystrophy. We do have an unspecified still, and other, as well as fascioscapulohumeral muscular dystrophy, which would be upper shoulder girdle muscular dystrophy. Less common, but there's a code for it. That was interesting. Maybe took a little too long. A little weird on your eyes, but we come to eye new conditions. Okay. Ectropion. Ectropion's not new, but the type paralytic ectropion of the right upper and lower, left upper and lower will all have their own codes. The example I've given is the right upper eyelid, and an ectropion is where the eyelid curls out and away and tends to expose the cornea excessively and causes drying out and so forth. An entropion is where the eyelid and eyelashes curl in, and that tends to scratch the cornea and cause other physical traumatic symptoms due to the cornea. Entropion is typically worse. Meibomian gland dysfunction. Meibomian glands are the oil glands that line the edges of the insides of your eyelids, and therefore the codes are oriented around the eyelids. And this would be perhaps a decrease or increased production of the oil that's associated with it. I've never personally encountered this as a clinician or as a coder. I do want to give you the caveat not to be confused with the hordeolum, which is the clinical term, or a sty, which is an infection of one of these meibomian glands. So if you see a purulent infected meibomian gland, be looking out for hordeolum, which is H00 family, not the generic meibomian gland dysfunction. So the gland is not dysfunctioning, it's infected. Minor change in conjunctivitis, it's a million conjunctivitis codes. Now we have rosacea conjunctivitis of the right or left eye or both. And I've given you an example code there. And this is one that's kind of interesting to me anatomically, brow ptosis, which is, it's kind of interesting that the eyebrow is being associated with the eye, not the face. Not for me to question, but example of brow ptosis left, H57.812. This would be distinct from facial paresis or hemiparesis, in which the brow may droop. However, I would caution you to be looking in the neurologic chapter for that, rather than in the isolated brow ptosis. I think we would find this mostly in a trauma or a cosmetic surgery case where the brows were just too low, but the rest of the face was functioning fine. In other words, not a neurological paralysis. Okay, now lots of changes, and honestly, all of them intuitive, to do with eyelids. So here's where I've rolled the neoplasm of the upper and lower eyelids forwards. That's why I skipped the neoplasm chapter before, just to put it here with the eyes. There are combination codes for conditions which tend to affect the upper and lower lids together. Blepharitis and lagophthalmos are examples of those. So rather than having to use an upper lid code and a lower lid code, now there's a combo code for both. Many other conditions, and namely the neoplasms, and that includes malignancies, such as melanomas, squamous cell carcinoma, basal cell carcinoma, also benign neoplasms, also nevi, like birthmarks, have upper and lower eyelid codes too. So it's kind of broadened that whole concept among them. Not hard to figure that out. As you get in there, just expect that chapter to have expanded somewhat due to the location laterality codes added. Here's one I put in. I think it's kind of a fascinating anatomical and pathophysiologic lesson, just to review how the tear system works in the eye. Epiphora is a condition of overflow of the tears due to a drainage problem, not an overproduction problem, not crying, but due to normal tear production not having sufficient drainage. Now the code change is simply to delete the lacrimal gland from the descriptor and just replace that with side. Partly because it's not really a problem with the gland, it's not overproduction, it's a problem with the drainage. And also because it's by definition lacrimal, so it's redundant to say lacrimal in the definition. But in any case, the tears are produced in tear glands in the lateral behind the eyelid up here, form the tear film across the cornea and conjunctiva, keep it wet, and also nourishes the cornea. Remember, the cornea has no blood vessels, so that's where it gets glucose. Oxygen diffuses through the tear film and keeps the cornea, the stromal cells, and the epithelial cells alive. And then it drains to the medial canthus through the inferior and superior nasolacrimal ducts, so-called, goes from the lacrimal flow in the eye to the nose, nasolacrimal. If one or both of these is obstructed or stenotic or has a stone, believe it or not, you can get stones in these. Epiphora may be the symptom that occurs. So if you ever see it, you'll know it, and maybe if you're like me, you heard it here first. On to circulatory. Okay, there's some really arcane, obscure ones, and there's one really useful code here. So we use the I63.8 family other cerebral infarction and expanded that for better utility. Let's start with the boring ones first. Boring unless you've got one of these conditions. For example, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. And I hope I never have to say that all in one sentence again, but it has its own code. Other hereditary cerebrovascular disease, too. And of course, we've just simply added the 9 to the code, and we've still recycled our other cerebral infarction. Now here's where we're going to get some traction as coders. I'm certain you've seen a lacunar infarct. So fortunately, there is a code for that. The main descriptor is other cerebral infarction due to occlusion or stenosis of a small artery, but it indexes to lacunar. And this is what you'll typically see on an MRI, CT, CTA. And if you're coding an outpatient type, you can confidently use that as your diagnostic code, or if it's inpatient, have that translated. And in my experience, most attendings are pretty decent about including that. So lacunar is small artery infarction. Now we've got a slightly more specific code there. Digestive system. Here's one I would encourage you to flip open your 2019 manual and just kind of have a look around. It's added more combinations of within the peritonitis, general and localized, whether there's perforation, gangrene, or abscess. Now, some of those codes already exist, but this sort of broadens all the possibilities. I personally would find it lucky as a coder to get that degree of specificity, but nonetheless, we hope for it. Now, acute appendicitis with generalized peritonitis presumes that there's a perforation. So it's simply with or without an abscess. Okay. But acute appendicitis with localized peritonitis may or may not have a perforation. So you see a without perforation and a with perforation. Peritonitis with or without abscess. And then other acute appendicitis, which is frankly probably what you're going to get most of all, without perforation, with or without gangrene. So a gangrenous appendix is the kind of thing that will be seen on an appendectomy, either by the surgeon or by the pathologist too. And you know how that works about whether you can code that or not, depending on the patient type. But a gangrenous appendix is, it's good to know, just to add that little specificity if you're a code nerd like me. Also in the digestive system, we have ischiorectal abscesses. Several other codes already exist, like the anal abscess, the rectal abscess / perirectal, anorectal, intrasphincteric. We've added a couple of other types. Horseshoe ischiorectal abscess involves the perianal area and is on the right and the left with a communicating sort of isthmus. So it's U-shaped, hence a horseshoe abscess. Recycling the other ischiorectal abscess, and then a superlevator is just simply another location that abscesses can form, another potential space. Different organ altogether, gallbladder, a couple of changes there. Cholangitis, really the most common kind we'll find is primary sclerosing cholangitis. So just adding the primary really captures the spirit of that, like the code I gave a few slides back. So we've recycled the other cholangitis, but primary sclerosing. Now we have K83.01. Then a couple of, you might say, add-on codes to the cholecystitis with or without cholelithiasis or cholelithiasis, gangrene and perforation of the gallbladder with cholecystitis. So wouldn't have gangrene or perforation without cholecystitis, so it's a bit redundant, but it does help you to remind you that when you're coding the cholecystitis, if there's a complication like that gangrene or perforation, you can capture that with these additional codes. Skin and subcutaneous. This is a little bit of a housekeeping code in the non-pressure chronic ulcer of other sites. For some of them that we're missing the skin of, adds the skin of. Now most of the other specific sites like the buttock will designate these by layers, limited to skin, involving the fat, involving the muscle, and the bone. But the other sites that don't have their own classification, just to remind us that it's the skin of for these particular codes. And just an example, L98.495, non-pressure ulcer of the skin of other sites, but can involve the muscle, but without necrosis. So it's still to say it involves the skin, but whatever additional layer below that as well. Now, the current culture of documenting pressure ulcers and non-pressure chronic wound ulcers is, in most places in my experience, pretty good. So you'll hopefully get a site, not need to use the other, but this sort of snaps that family into line with the other named sites. Myalgias, a little bit of a disappointment here, and as far as how much it was expanded, but nonetheless, myalgia has an other, an unspecified, and then these two particular special cases, mastication muscle, chewing muscles, and the auxiliary muscles of the head and neck. So neck muscles, I wouldn't say just plain neck myalgias would qualify, unless it indexes that way or there's a coding clinic that says so. The auxiliary muscles, not the primary muscles of the head and neck. I can assume that there was some squeaky wheel orthopedist who demanded that this be put in, and now we have it. Genitourinary system, mostly to do with urethral strictures, and mostly the other and unspecified types. So previously we've had very good code choices for post-traumatic and post-infective as far as the location of the male urethra, because the male urethra is much longer than the female. You see right here. So the reconstruction or dilation of the anterior urethra is much different than the posterior. And if you're coding CPT, there are distinct codes for this as well. I don't imagine there's a NCCI edit for that yet, but it's not impossible that they would build something like that in. The female urethra is quite short, and there aren't any really regions to speak of too, and less often to be affected than the male urethra. So the locations, for example, are anterior, posterior, and overlapping that you'll see. Again, these are just added to the other and unspecified, and sadly, oftentimes that's all we'll get. It's just anterior urethral stricture. No mention of the etiology, or if the etiology isn't post-traumatic or post-infective, this is the kind of code that you'll use, but at least we've got now that region to choose from for specificity. In the pregnancy section, we have a couple of changes. In this particular one, it's a small adjustment to account for different circumstances of identical and fraternal twins and combinations of those in certain ways. But it's kind of interesting to pause and review the physiology of how twins and multiple gestations tick. In the diagram down below, we're looking at twins. We just take this knowledge and then expand it into the code changes I'll describe in a moment. So this family of codes is the circumstances of multiple gestations. It can be used in the first, second, or third trimester under any circumstances where the patient is receiving care, whether it be delivery or prenatal or some other condition in which the pregnancy is relevant in outpatient or otherwise too. So what this designates is whether the multiple gestations share or don't share a chorion, and by the way, the chorion count equals the placenta count. So the chorion membrane is essentially an extension of the placenta that extends all the way around and kind of lines the uterus. That's the outer membrane, and then the amnion is the individual membrane right around the fetus. So it all depends on when, in this example of identical twins, the split of the fertilized ovum occurs. If it occurs prior to implantation, it effectively takes one fertilized egg and creates two separate fertilized eggs that implant in separate places in the uterus. And so we have a dichorionic, biamniotic situation. So two separate placentas, two separate sacs, amniotic sacs around the babies. Now, if it occurs immediately after implantation at days 4 through 8, the placenta has already formed. But at that point, if the fertilized ovum splits, each of the developing embryos and then fetuses develops its own amniotic sac, even though they share a placenta. That's monochoriotic, diamniotic. If the cleavage occurs much later after implantation, they've already formed the placenta, already formed the amnion around it, so that both of the fetuses occupy that same amnion. Now, as far as the intricacies about how that affects outcomes and deliveries and so forth, I'm not sure, but it's important enough that there is a code family, so we should avail ourselves of knowing this. Now, previously, for triplet, quadruplet, and other multiple gestations, the concept only allowed monochorionic, monoamniotic, or two or more. So what if you have a triplet? If there's two that share an amnion like this, and then a third one that's diamniotic, there's no really way to capture that, or if there's no way to distinguish that from the fact that if all three of them are trichorionic, triamniotic, now that we have that choice for triplets and quadruplets, and it sounds really nitpicky to have that, but I had a friend once who he and his wife had in vitro fertilization, and they put in two fertilized ova and one of them twin. So they had one monochorionic, monoamniotic twins, and then they had a separate chorionic, amniotic triplet. So it was twin sisters and a fraternal brother. In any case, now we could have captured that circumstance in the codes where it was triplets but two amnion. Now, there's a interesting, I think, very useful concept added both to obstetric wounds and surgical wounds. So stay tuned for the surgical wounds, but we'll start off with obstetrics. So that's where we are in the book. Infection of obstetric wound, formally, that's the extent of the code choice. Nothing to do with depth or location. What we've done is added the depth and location and involvement of an obstetric wound in the current context here. Superficial, deep, organ or space like the peritoneum, like peritonitis, sepsis arising from that wound, which is distinct from postpartum sepsis and other obstetrical site. I would caution you to be observant of the uterus being the infected organ as to whether it is the substance of the uterus or the lining of the uterus. Endometritis, 086.12, is a completely separate code, and that can occur from a vaginal delivery. So it has nothing to do with an incision, but can also occur in a C-section. So then we get into the business of whether it's the incision which was infected or simply the lining of the uterus. And that may require a bit of query and a little digging around. There is an example, 086.01, which would be, I think, the most common. You'd see a superficial infection of the obstetrical surgical wound. Also take care to note, this is not just C-section incisions, also for a episiotomy repair. That is an obstetric incision, and if infected, it can affect all of these up to and including an organ, for example, like a deep, more like a space, like a ischiorectal abscess, or even sepsis. So if you're an astute coder, you'll remember that all of those are mom codes. Now we'll move on to newborn codes. And we have an expansion of the substances affected by maternal use of the substances affecting the newborn. So previously, this concept included newborn affected by maternal use of medication, which was anesthesia or analgesia. That was pretty much it, except for cocaine. Now we've expanded this. Some of these are slam dunk easy. Some of them I think are going to require a little coding clinic clarification, but I'll step through these. So newborn affected by maternal use of antineoplastic. Mom had chemotherapy while pregnant and is somehow documented to have affected the newborn. So there's a specific code for that. Antidepressants, if it affected the fetus or the newborn. Opiates are both prescribed and substances of abuse. So my tentative advice is going to be that presume that these are prescribed opiates to use this family of drugs, or this family of codes. Amphetamines are prescribed, but the preponderance is of it's a drug of abuse or addiction when used in pregnancy. Now, what makes it a little more confusing is separate set of codes, P04.8 instead of 0.1, which are newborn affected by maternal use of drugs of addiction. So presumably these are non-prescribed drugs and may also include the likes of opiates and amphetamines. And the example I've given here, P04.14, newborn affected by maternal use of opiate, would be the prescribed type. Now, some of these are obvious drugs of addiction, hallucinogens, cocaine. Those are never prescribed, so those will be very obvious. But the opiates, I think, is going to require a little bit of clarification. There's another other noxious substance, too, which is just after this section, which includes P04.81, cannabis, which is, I guess, probably categorized that way because it's a drug, but it's also the smoke and the carbon monoxide and other substances that are in there. That it's not strictly a drug mechanism, but it is a combination of substances which can affect the newborn too. So if you have a cannabis smoking mother and it affected the newborn, look out for that code. This was handy clinically and coding wise, electrolyte disturbances in the newborn, because they're always specified clinically, whether hypo or hyponatremia, sodium, kalemia, it's potassium, chloremia, chlorine, and they're all hyper or hypo. Throw in the alkalosis of newborn as well, and we've reused the other electrolyte disturbances, other transitory electrolyte disturbance. So I could see these getting a lot of traction in newborns because based on the basis of the lab result, the clinician can make the diagnosis. We don't. We're not the diagnosticians, but they say hyponatremia, bam, P74.22. Unrelated to electrolytes, we have a couple of new codes that are relevant to newborns and one of them to adults too. P35.4, congenital Zika virus disease, this is a tragic, potential outcome of Zika virus infection in the mom, which itself is fairly benign, but the congenital Zika virus disease. We have a new code. And then perhaps a patient that's been traveling has been exposed to it and warrants careful monitoring, ultrasounds, whatever kind of intervention it needs. There's a Z code, which I put the cart in front of the horse there, contact with and suspected exposure to Zika virus. I just included those two together because they're so close conceptually. Another congenital condition having nothing to do with infectious disease is other doubling of the uterus. This just adds another element of specificity, and this is the other doubling. Let me start by saying doubling of the uterus and cervix, which is having truly two uteruses. Bicornuate uterus is where the fundus of the uterus is split into two distinct horns, like this, separate from one another anatomically, one or both of which can get pregnant. And then unicornuate uterus is one of those is somewhat smaller, and there's a dominant horn which can usually host a pregnancy. So those are kind of the obvious full-blown double uteruses. The new codes come in, essentially our septate uterus. It indexes this way as well and has different clinical implications. So there's other complete doubling of uterus would be a full septate uterus, and other partial doubling would be a partial uterine septum. Sorry. There's also the other and unspecified. So that just adds a couple of possibilities that you might see on an obstetric or gynecology chart. Some chromosome deletions. Some of these codes already exist. We've just added Angelman syndrome, Williams syndrome. Those are often referred to by name. Not hard to grab those codes. Here's some examples of existing codes which are designated by both the chromosome and the eponym for the syndrome itself. So deletion of the short arm chromosome 4 Wolff-Hirschhorn, or of chromosome 5 Cray-Duchat, which is French for cry of the cat. And these babies apparently have a cry that sounds like a cat meowing. Signs, symptoms, abnormal findings. So here are some findings in urine which may predispose a patient to certain types of kidney stones, even if we can't get a hold of a kidney stone to analyze it. This is why a patient with a kidney stone, we give them a strainer so they can capture the stone, send it for a chemical analysis, and to determine if it's a hypersecretion or a metabolic disorder or a dehydration disorder or an infection based on the chemical composition of that stone down here. But in the absence of a stone, just by measuring the citrate level, oxalic acid, uric acid, or calcium levels, we can sometimes help determine if the patient is likely to develop a stone and which type. So oxalic acid, uric acid, and calcium, those are actually components of different types of kidney stones. Citric acid is in hypercitraturia. That is usually holds those salts in solution so they don't form stones, but if there's a decreased level of citric acid, that can predispose a patient to kidney stones. There's a couple of other odds and ends in the other urine findings like acetonuria and bacteriuria. We've all seen that one too. So there's getting the mindset of thinking about these too. Incidentally, calcium oxalate crystals or kidney stones account for about 80%, calcium phosphate, 5 or 10%, uric acid, or 5 or 10%. And that last one is radiolucent. It does not show up on x-rays. Probably shows up on a CT just from the circumstantial findings around it. That's a little trivia for you. In the injuries, this is a completely mundane code correction, but just an important re-review of anatomy for you. For middle phalanx fractures in the ring, little, other and unspecified fingers, for some reason, they had labeled it, instead of middle phalanx, medial phalanx. So we changed medial to middle. It was correct in the index and long finger. The thumb doesn't have a middle phalanx at all. But just remember that medial means towards the midline and is the opposite of lateral. So a phalanx can't be that. And even in anatomical position like the Leonardo da Vinci drawing, there's nothing medial about that phalanx too. So just keep that in mind so when you're reading something anatomical, you know what you're dealing with. Here's an example code of that. Into the T chapter, which is sort of the wastebasket term for external causes. One for poisoning, adding ecstasy or MDMA, adding poisoning by all intentions. And remember, this is not the intention to consume, but the intention to harm or not. So self-harm or assault versus intentionally taking it, which is usually the case, but accidental poisoning or overdose by MDMA. Previously, ecstasy was indexed to amphetamine, which it shares a root molecule with. MDMA is methylene dioxymethamphetamine, but it really has very different effects due to an additional molecule that causes it to act more on the serotonergic system than on the dopaminergic system. Here's an example of probably, I think, the most common code that you would use: poisoning by ecstasy, accidental, initial encounter. So the patient meant to take it, didn't mean to overdose on it. Interestingly, societal and physical harm caused by various substances, by comparison, going counterclockwise, heroin is the worst, and steps down and down various other drugs of abuse as far as the harm to the patient and to society, and the likelihood of dependence. And you'll see that ecstasy is really quite low, lower than by far than tobacco or alcohol. Also in the T chapter, complications. This should look familiar as your obstetric incision. Also, same exact choice as superficial, deep, organ in space, sepsis, or other. And naturally, you have an initial, subsequent, or sequela episode of care as your seventh character. And an example of that, T81.42XA. Infection following a procedure, deep incisional surgical site. Initial encounter. And don't forget, that's initial encounter is active care, not just the first and only time the patient walks in the clinic or hospital, but as long as they're receiving active care for that. Subsequent is during healing. Sequela is after healing is done, but they're still receiving care for some other associated after effect. And then also T, consequences of external causes. This is a new concept in ICD-10, and that is labor exploitation, slavery, and sexual exploitation. The choices are adult or child, confirmed or suspected, and as it is in the T chapter, we have initial, subsequent, or sequela. And there's also a history of Z code in there too. Any sexual exploitation of a child is forced, so that the forced is not in the child term, whereas it is in the adult. And I guess labor exploitation of adults can occur without being forced, but it is specified in the child. Just a little nuance there. An example of a patient who may have been subject to trafficking and sexual exploitation and is being worked up for that, and then medical legal circumstances being confirmed, but not yet. T76.51XA, adult forced sexual exploitation, but suspected initial encounter, as an example. Some Z codes for encounters of those same things. Victim following forced sexual exploitation or following forced labor exploitation. So if a patient is just coming in for a sexual assault nurse examiner exam, nothing is known about it yet, they're just being examined for that. There's a Z code. Forgive me for not putting the actual code there, but you can look it up. Consequently, more useful screening reasons for screening for depression or maternal depression, those are important. Glad to know there's Z codes there now. And then other mental and behavioral disorders as well. And then finally, there is the personal history of forced labor or sexual exploitation, because that kind of thing doesn't ever fully go away. Even if there's no sequelae, that's a Z code that further tells the story of the patient's personal health history and current circumstances as that may have affected them. Also, some other screening Z codes for kids, childhood, autism, global developmental delays. I know there are practices that do those all day long. Now there's a Z code for that. And other developmental delays, other and unspecified. So autism, global, other and unspecified. So just a screen for unspecified developmental delays, Z13.40. Now backing up a little bit to the external cause, this is just kind of a funny, we have the grammar police have gotten their hands on ICD-10. Did you know there's no such thing as a baby stroller, one word? It's been made into baby stroller. But they're not arbitrarily just splitting words apart, because snowboarding became snowboarding. And tobogganing, that was kind of fun, but that's in there. I confirmed it. And then to go along with, sort of go along with the new hyperlipidemia codes, family history of elevated lipoprotein A, and other disorder of lipoprotein metabolism too. So these may be reasons to screen a patient or be more aggressive with treating patients with certain serum levels of these if they've got a family history of it too. I think that's where those might be used. So that's all I have for you for 2019. If you are an inpatient coder or otherwise just kind of interested in PCS, I have a companion 2019 PCS code updates presentation. I would encourage you to check that out. And I hope to see you around, but at the very latest, 2020 ICD-10 CM and PCS updates coming up in about a year. Until then, be well, take care.